topic today, okay. The topic today is polytrauma. And this is a patient that has an injury someplace in the world. And the management of patients with multiple injuries is really challenging, with improvement in pre-hospital care and advancement in early diagnosis of life-threatening injuries. The mortality in polytrauma patients have declined. It has declined over the years. Why? Because we're developing an experience on how to deal with these multiple injuries. هيدي عم ضايقني هي ما بعرف كيف بدي اشيلها. شو بقى can start collaboration with the host on who can start a collaboration؟ لا في شيء مضايقتني هاي ما عم بقدر شيلها. هاي شيء وحده سوداء بالوجه.
دكتور هي من عندنا ولا من عندك؟ مش عارف.
من عندي ما عم بقدر شيلها عاد بوجه السلايدز.
تماما يعني؟
ايه
تماما بوجهه ولا بتحت يعني بيجي؟
لا جاي بوجه السلايدز ما عم بقدر اقشع السلايد. وحده سوداء اللي محطوط عليها ميوت ستارت فيديو participants etc. هيدي ما عم بقدر شيلها. بعطيك الريموت كنترول بلكي تشيلوا لي اياها.
اي الشباب يعرفوا يعني اكثر منها.
ريموت اوتو اكسبتد ريكوستد. لا ما في ما راح تمشي. طيب على كل حال the major trauma is still one of the leading causes of death amongst young adults in the industrial world. Furthermore, it has a severe socioeconomic impact and can result in devastating morbidity, especially among the working population. Specific problems associated with initial assessment of polytrauma victims in the emergency department includes patients being confused, unconscious, under the influence of drugs or alcohol. These 3 or 4 conditions let us miss the diagnosis of certain organ injuries. Whenever you get a patient who is under the influence of drugs or alcohol, or even if he's intubated from the emergency receival at the site of the accident, all these cover up for the diagnosis, and you should be very aware of this. It is often very difficult to get an accurate clinical history, and life or limb-threatening injuries are not apparent in most cases. يعني بنفنش كتير. ليش؟ لأن في cover up. أيضا بجيبوا لنا مريض غايب عن الوعي. Either the emergency medical technician doesn't give you a good history. So this is what we're trying to improve over time. Accurate interpretations of the available clinical signs and mechanism of injury are the key features to avoid missing potential life-threatening injuries that may endanger the patient's life. Most emergency departments in the United Kingdom work with an agreed round-the-clock multidisciplinary trauma team. The multidisciplinary trauma team is already present. It includes several specialties. These are always available in the trauma center. It is the job of the emergency medical technician to inform these, to be organized and prepared to receive that particular patient. Okay? Now, the hospitals are usually informed of these patients by the pre-hospital teams at the accident scene. يعني بمنطقة الaccident. Whatever they can give, they should send information to the trauma center. They should send information to the multidisciplinary group who is going to take care of this patient. This allows adequate time for the team to assemble and resuscitate patients in an organized manner, following advanced trauma life support guidelines, algorithms. The trauma team consists of an anesthesiologist, a general surgeon, orthopedic surgeon, radiologist, and an emergency department consultant who usually acts as a team leader. لازم تعرفوا إنه هولي لازم يكونوا موجودين بالhospital at all times. If you have a respectable trauma center, it is important to follow an agreed guideline, as deviations from the standard protocols have shown to increase mortality in major trauma patients. They should follow a certain system. They should rehearse the training on patients who act to be patients, yani acting patients. And by doing this, there will be an organogram. Each one will know his job. The surgeon will know his particular job. The anesthesiologist would know whether he should put the patient to sleep or not. The orthopedic surgeon should know that he's going to take care of the fractures. The radiologist should read the radiology. The emergency department should always be available and have all the people, the instruments available way before the patient comes. So keep this in mind. This is for the hospital. This is for the team. If you want to have a high quality team, the emphasis of managing polytrauma patients are largely based on the golden hour in shock. I mean, what do I mean by the golden hour in shock? We know that if we deal with trauma patients in the first hour, the proper way, we would give them the best chance to survive. This is the golden hour in shock. This calls for a focused and effective recognition and treatment of life and limb-threatening injuries. Radiological assessment is an essential part of this strategy. The primary radiological survey is undertaken within minutes of the patient's arrival in the emergency department. Now, let's see. I have to get this out of this. Now, these include an anterior posterior view of the pelvis, a posterior anterior view of the chest, and a single adequate lateral view of the cervical spine, including C7. Why do we include C7? Because we miss C7T1 injuries. So we have to take either swimmer's views. We have to add additional imaging so as not to miss them. These images can help in early diagnosis of possible life-threatening injuries like severe bleeding or unstable fractures that might cause permanent disability in a trauma patient. خالد عم بيكون في حكي كثير. Focused assessment with sonography for trauma. Scans are used as an adjunct in the emergency department to help detecting major abdominal and pelvic organ damage. You can miss these. You need a special radio imaging. You need a special experienced people, how to do a sonogram. In Europe, they depend a lot on sonography and ultrasonography to make diagnosis of abdominal and pelvic organ damage. Results of these investigations have a direct impact on the further diagnostic and therapeutic strategy, such as transfusion, immediate surgery, urgent transfer to specialist trauma centers. A conventional computer tomography is what we used to use in the past. We used to waste time sending our patients, and we used to risk the life of the patient being in the CT scan room. So now what do we have? We have a spiral CT, which is present in the emergency room. You can take various cuts, various sections, while the patient is in the emergency room. Please, I'm not hearing. خالد في صوت. خالد
يا
في
شباب
صوت.
شباب ايوه دكتور بسمع الصوت. يا صلاح ممكن تسوي كنترول الصوت هذا من بيجي؟ صلاح.
اوكي دكتور.
Look, if they're not interested, we'll cancel the lecture. شو رأيك؟
No, continue دكتور. لا عادي. هو
I'm
يمكن واحد.
trying to give this lecture for the benefit of the hospitals, for the benefit of the residents.
Okay,
this
sure.
We ask quite often in examinations. Okay?
Yeah. Okay, sure.
Okay.
Thank you.
So we need a CT scan. A spiral CT could tell us a lot about pelvic ring lesions. It can tell us about the brain. It can tell us about the thoracic spine and the abdominal viscera. A conventional CT scan takes time, and it's risky to follow up the patient in the room while doing the CT scan. There are practical limitations, therefore, of the CT scans. In this group, like risks of transferring intubated patients from the emergency department to the CT suite, as the procedure is time consuming. Every minute counts. Furthermore, it was often perceived as a waste of time when such patients warranted emergency surgery. We cannot waste time. Any time that is lost is against the patient. There is evidence that clinical evaluation of polytrauma patients based on conventional history taking, clinical examination, and conventional CT scan is often time consuming. We like to save time. With the introduction of spiral computed tomography, and particularly multi-detector, multi-slice CT, this scenario has changed considerably. Multi-slice CT leads to reduction of the scanning time due to an increased speed of the image acquisition. لما نعمل السبايرال سي تي بنكون عم نعمله بربع الوقت يلي بنكون عم نعمل الكونفنشنال سي تي. فكل مستشفى باليمن لازم تجيب سبايرال سي تي اذا بدها تتعامل مع التروما. Multiple body parts can be examined with a higher resolution, and there is the ability to obtain multiplanar reconstructions and immediate on and offline interpretation of images at separate workstations. These important aspects contribute to the introduction of multi-slice CT in the primary survey. تعرفوا إنه في primary, secondary survey, or third survey, meaning each time we follow a certain system. In the primary survey, when we included the spiral CT, it meant that we included a section where it does not take time. It doesn't waste time from saving the life of that patient. The main advantage of multi-slice CT include a significant reduction in time required to undertake these scans. يا شباب لما بجيكم patients هيك لازم تجربوا توفروا وقت. خليني اخبركم شغله. هون بلبنان اذا في accident المريض مشلوح على الارض بس بعده طيب، بيوقفوا كل شيء في السيارات بدهم يتفرجوا عليه. هول كلهم عم بيضيعوا وقت الحياة على الحياة تبع المريض. You should act swiftly and quickly. Clear the patient at the accident scene and send them to the trauma center. Some patients, some studies indicate they can be performed within 20 minutes of presentation to the emergency department. تصور 20 دقيقة من بعد حادثة يكون المريض صار بالdepartment. Hey, by doing this, you are saving the life of the patient, and the time taken to perform the scan can be as little as 6 minutes. This is almost 50% reduction in the time taken compared to the conventional CT scan. The main limitation of this technique is availability of a trained radiologist. You have to be organized. You have to have available a trained radiologist and a radiographer round the clock. بدهم يكونوا موجودين كل الوقت بالمستشفى. The CT suite should be adequately equipped so that the patient can be resuscitated simultaneously whilst having the CT scan. Conventional CT scan of the head, chest, abdomen, and spine is included as an adjunct to the secondary survey. Helical contrast CT has been shown to be accurate for blunt aortic injury. If you see driving a car and the steering wheel hits on your chest, you can rupture your aorta. A CT scan should be undertaken liberally. Patients who are hemodynamically abnormal should not be placed in a CT scanner. A properly performed and interpreted helical CT that is normal may require transfer to a higher level of care. Okay. The ATLS guidelines suggest that CT imaging is a time-consuming procedure and should only be done in patients with no hemodynamically abnormalities and where there is no apparent indications of an emergency laparotomy. Some gastrointestinal and diaphragmatic pancreatic injuries may also be missed on CT. Evaluation of the bladder and pelvis using CT scan is an alternative study that is useful in providing additional information. يعني هيدي الأسود هي عم تضايقني. Suspected urinary system injuries are best evaluated by contrast enhanced CT scan. During evaluation of blunt trauma, if there is early or obvious evidence that the patient will be transferred to another facility, time-consuming tests like CT should not be performed. In penetrating trauma, double or triple contrast CT are useful in flank and back injuries. So في an indication of CT for certain organs. Contrast enhanced CT scan helps to assess the retroperitoneal colon on the side of the wound. It has been reported that CT scan is most specific, 92 to 98% in blunt abdominal trauma. The disadvantages are the cost and time for transport. It is recommended that all newly built CT suites should be near the emergency departments, ensuring quick transfer of the patients with minimal movement. لحد هلا, am I clear? Okay, now we're coming to the interesting part of the lecture. We gave an introduction. We gave how the emergency medical technician, he should know how to remove the patient from an automobile accident. He should suspect the cervical spine fracture and put a collar. If he has a back fracture and he suspects it clinically, he should put a corset. These people should be trained with extraction of the patient from the center where he sustained the injury. Polytrauma means a syndrome of multiple injuries with systemic traumatic reactions, which may lead to dysfunction or failure of remote organs and vital organs. Polytrauma is not a synonym of multiple fractures. Multiple fractures are purely an orthopedic problem, as there is involvement of the skeletal system as a portion of polytrauma. While in polytrauma, there is involvement of more than one system, like associated head injuries, chest injury, spinal injuries, and abdominal or pelvic injuries. Polytrauma needs management, as I've already stated, by a team of surgeons and physicians. Orthopedic surgeon is one of the team members of the trauma unit. Orthopedic injuries are generally not life-threatening unless they result in significant hemodynamic instability due to the loss of blood. Worldwide, #1 cause of death amongst the younger age group is multiple trauma, 18 to 44 years. And it is the third most common cause of death in all age groups. Over here, we have an injury secondary to a high velocity injury, a motorcycle. You see by the side of the motorcycle, the individual is dead. This patient is between 18 to 44 years of age. Now, in the USA, loss of income due to death and disability resulting from high velocity trauma totals $75 billion annually. The causes can be motor vehicle accidents, industrial accidents, falls from heights, gunshot injuries. In 1994, in the USA, there were 38,500 deaths alone from gunshot injuries, and 90,000 to 100,000 non-fatal injuries in the USA related to firearms, related to gunshots. Gunshot wounds occur 90 times more than any industrialized country in the world. So keep this in mind. This is USA. Other causes of injury, we know that recently we had the tsunami, we had volcanoes, and we have war injuries. What about the team organization? The treatment of complex injuries in multiple organ systems demands a team approach. The team must be able to evaluate the patient swiftly, be willing to discuss the effect of the management of one problem on another. It should also be able to arrive at decisions quickly and efficiently in regard to performing life-saving procedures. Death and polytrauma. You can have an immediate death, as I showed you in the motorcycle accident. You have a death within 4 hours, either early in the hospital or on the way to the hospital. And you have a late death, which occurs in 2 to 3 weeks. So you have to keep this in mind. The first peak of death, immediate trauma death. This patient was riding on a motorcycle. He made an accident. He came landing on his head. He had a severe head injury. He had a brainstem injury. He had a high cord injury and a heart and major vessel injury. And these patients have massive blood loss. He died on the spot. A second peak, which occurs within the first 4 hours. These can look at the fellow driving. He has a coffee cup in his left hand and the sandwich in his right hand. He hardly is holding the steering wheel. They die from intracranial bleed, chest injury, abdominal bleeding, pelvic bleeding, and multiple limb injuries. And the third peak of death, which is a late death, which occurs several days or weeks due to sepsis and organ failure. The aims in management to restore the patient back to his pre-injury status, having following priorities. First of all, life salvage. We want to save the life of that patient. Limb salvage. We want to save that extremity. And salvage of total function, if possible. So all these put together is our aim. What about life salvage? 50% death due to trauma occurs before the patient reaches the hospital. 30% occurs within 4 hours of reaching the hospital. 20% occurs within the next 3 weeks in the hospital. If preventive measures are taken, 70% deaths can be prevented, meaning that 30% deaths are non-salvageable deaths. The team of consultants, I repeatedly put it, this is the list of consultants. This is of how the patient is on a table with the consultant surrounding him. And if you look at the extreme right, you see a nurse and the doctor holding the flow sheet. Everything is being taken care in an organized fashion. Each one knows what to do. The urologist, if he sees blood on the meatus, what should he do? The orthopedist, the fracture, how should he splint it? The anesthesiologist, how should he intubate? The general surgeon, how should he know whether there's any organ injury, etc., etc. So this has to be organized. It has to be rehearsed in the hospital several times on artificial patients in a quiet way. And there should not be one opinion. It should be multiple opinions. So it's a multidisciplinary approach, integrates organ and injury-specific treatment protocols. The level 1 facility must have, we mentioned, a radiologic suite, high-quality radiographs, spine, abdomen, chest, pelvis, extremities, emergent angiography. I will be talking about it later on. Computed tomography, we spoke so much. And in operating room must be staffed and ready 24 hours a day to manage emergency chest, abdominal, head, and pelvic and extremity trauma. Now we're coming to an area. Okay, access to diagnostic studies is a must. Interventions should be available. Line care should be directly available and inserted. Respiratory support must be available around the clock. Nurses should be familiar with the protocols for mobilization, deep venous thrombosis, pulmonary and bowel care. Immediate, early, and late. Let's go into elaboration. I told you there will be several repetitions, but you have to keep this in mind. Immediate death by severe head injury, or transected aorta can only be dealt with by prevention and public education. عم برجع بعيد. واحد لما ياكل ضربة على راسه يقتل بده يكون عقله كامل ما بده يكون فاضي. You should not be directed to impress other people by driving fast or on a motorcycle. Early deaths often have correctable injuries, such as epidural or subdural hematoma. The resident should be alert of how to diagnose these. Hemopneumothorax, spleen, a liver wound, or blood loss from multiple extremity injuries. He should be aware of these. He should know how would an epidural patient present, or a subdural hematoma present. How should one with a pneumothorax present? How should one present with the hemothorax? What's the problem? Does he have a cardiac tamponade? You have to know these points. You have to know them. We ask them. We love asking them. And late death, he should know why do they die? From sepsis and multiple organ failure. So you have the advanced trauma life support. These are 4 interrelated stages. Rapid primary survey with simultaneous resuscitation. يعني هو عم بيعمل survey بيكون عم بيعمل resuscitation. مش يعمل survey وينسى resuscitation. Detailed secondary survey, meaning after doing the primary survey, you could make mistakes, you could miss conditions. You have to do a secondary survey. And this should be repeated many times. And you have a constant reevaluation and initiation of the definitive care. Don't delay it. You make your diagnosis, you start the treatment when indicated. What's the pre-hospital phase? The basic emergency medical technician skills, maintenance. What does he do when he arrives to the scene? If the patient cannot breathe, he should make an effort to open the airway, insert an endotracheal intubation. But this is contraindicated in certain areas. Why? Because the tube might be out, and this might be a cause for the death of the patient, or he can rupture the trachea. If the EMT specialist is not well acquainted, he should put an umbo bag, breathe the patient till he arrives to the hospital. Cardiopulmonary resuscitation. You should have isotonics, saline. You should have Ringer's lactate. You should have Hemosil. You should have these products with him so as to try and compensate for the immediate loss of blood. So he has to have fluid replacement by isotonic solutions, reduction and splintage of fractures should be done, and he should send the patient to perform a primary survey to see if there are findings that were missed. This shows you a patient who is unconscious. The nurse is working on the IV. The anesthesiologist has intubated the patient, and he has a colleague by his side working on the patient. This is a patient who sustained multiple injuries, and it goes to show you how we splint these patients as one log. This is looking from the other side of how we splint these patients. We put sandbags on the side of the head. We put a collar. We splint him as one block. It should be a triage. It should be a triage. Triage is usually used in a scene of an accident or mass casualty incident to sort patients into those who need critical attention and immediate transport to the hospital and those with less serious conditions. This shows you of how the patient should be transported. If the distance of the scene of the accident is 50 miles, he can be transported by an ambulance. If the distance is between 50 and 150 miles, he should be transported by a helicopter. And if it's over 150 miles, he should be transported by an airplane. The golden hour that we already spoke about, rapid transport of severely injured patient to a trauma center.
وين ماشي؟ تعال اعطيني كيس وعدي.
ما عم بسمع.
ها؟
ما عم بسمع.
Bring.
Hello, مين؟ Okay, rapid transport of severely injured patient to a trauma center within 1 hour. The chances of survival diminishes after 1 hour. So, pay attention. You have 1 hour. You have to try and transport that patient before the termination of 1 hour and be working on the patient. Don't waste time. You should not waste more than 10 minutes at the accident scene. At times, it's difficult to extract the patient. يا جماعة عم بسمع حكي. Please. في ولاد وكذا.
عفوا دكتور الزميل اللي فاتح المايك لو سمحت تقلبه.
Okay. So coming back to the primary survey, we come to the ABCDEs. You all know it. You should know this. You should memorize it. Life-threatening conditions are identified and management is instituted simultaneously. I repeat, you have to pay attention to airway obstruction, tension, pneumothorax, hemothorax, open thoracic injuries, a flail chest, cardiac tamponade, massive internal and external bleeding. Now let's go into each of these. Rib fractures, we know, are quite common. And these can penetrate the lung and they can result in lung contusion. You have to be aware of this. So you have to monitor the pulse with the pulse oximeter, or you should do special gases, so as oxygen determinations, to see what is the level of oxygen in the blood. You should be sure, try and know what are the signs of acute respiratory distress. Patients with severe chest injury, these should be done, and they are life-saving procedures. You will end up with a flail chest. You'll end up with paradoxical breathing. Instead of expanding, it contracts with each inspiration. So you have to know these. These can be life-saving. What's a flail chest? 2 or more adjacent ribs broken in 2 or more places produces free floating chest wall segment. The chest wall becomes unstable. It's usually second to blunt trauma. It's more common in older patients. Why? Because they're osteoporotic and their ribs are very weak. The incidence of flail segments is 10 to 15% in patients with major chest trauma. Evaluate breathing to determine patient ability to ventilate and oxygenate it. Critical findings include the absence of spontaneous ventilation, absent or asymmetric breathing sounds consistent with either pneumothorax or endotracheal tube malposition, dyspnea, hyperresonance, or dullness to chest percussion, suggesting tension pneumothorax or hemothorax. Gross chest wall instability or defects that compromise ventilation, flail chest, sucking chest wound. Gentlemen, I just have electricity and I want to put the air conditioner on. Please, half a minute. Sorry about that, but I needed to put the air conditioner. Then in Lebanon, it's suffocating. This shows you how we put the tube in. If we have a hemothorax, it would drain the blood. Okay? I will show you more details. Sometimes you get pericardial injuries with hemorrhage in the pericardium. So how should you do it? How should you put a needle, a bore needle, in to drain the pericardial sac? You go to the xiphoid, with the angle of the needle at 15 degrees, and you aim at the opposite shoulder. You will go into the apex, and then you can drain the blood. So let's go back and speak. These are all signs of airway obstruction. I listed this. You should look for agitation, rib retraction, deformity, foreign material. The speech would be slurred. They're not breathing. They have hoarseness. They have a noisy breathing. They have a gurgle. They have a stridor. And if you put your hand on the chest, you can feel a crepitus telling you that there is multiple rib fractures. There's tracheal deviation. You can feel it. And most probably they have a hematoma. So you have to think of this. When to ventilate? When the patient has apnea, hypoventilation, a flail chest. Think of a high spinal cord injury. What I mean by high spinal cord, above C4. Why? Because the diaphragm is paralyzed. So you need to ventilate. You need to put the tube in. You need to give him oxygen. You need to give him positive pressure breathing. At times you have diaphragmatic injuries. I've seen ruptures of the diaphragm at its insertion. Head injuries, when you do the Glasgow Coma score and it's less than 8, these patients are moribund. You need to ventilate. Patients are hypercapnic and have hypothermia. All these are indications when to ventilate the patient. This shows a patient with the trauma team working around the clock, around the patient, each one doing his job. And believe me, no one opens his mouth. I'll tell you, when everybody's talking, there will be confusion. Each one should know his job. And to know his job, this needs training. This needs practicing. You should create your trauma team and you should create your artificial patient and work on him on a day-to-day basis. You can maintain an airway by using masked oxygen, an endotracheal intubation, an ambo bag. Protection of the spine is very important while giving airway maintenance. And this is something I've realized in multi-trauma patients. Immediately, if there is no trauma team, the anesthesiologist comes and hyperextends the neck to put the endotracheal tube, to put the tube in. My goodness, that patient would be lucky if he is not paralyzed. What are the causes of major bleeding? You can have external bleeding from an open fracture. You can have thoracic bleeding. Pelvic bleeding is very common. We see it. We see them coming nowadays with these autostrat accidents. Intra-abdominal bleeding, long bone fracture bleeding. This is a patient who was operated on and he had a transection of his internal iliac artery. External bleeding, inspect and apply local pressure. Thoracic bleeding, take chest x-rays and intercostal drainage from tube insertion. Pelvic bleeding, take pelvis x-rays and apply a pelvic binder on an external fixator. Intra-abdominal bleeding is confirmed by clinical findings, by CT scan, by a Doppler, by ultrasound. Long bone fractures can be fixed or splintage can be applied. Maintenance of circulation, IV fluids. One should put two IVs, one above the diaphragm and one below the diaphragm. And he should be receiving crystalloids and colloids. Now, what is hemorrhage? The classification of hemorrhage. A 70-kilogram male loses 5 liters, has 5 liters of blood. Okay, a class 1 hemorrhage is loss of 15% of the blood volume. This does not cause a change in the blood volume or pressure. These are treated. يا جماعة ما بسمع. Please. These are treated with 1.5 liters of Ringer's lactate or 1 liter of Hemacell. Class 2 hemorrhage, where they lose 15 to 30% of blood volume. It results in increased pulse, but no change in blood pressure. They are resuscitated with a crystalloid, but some may require blood transfusion. And you give these patients 1.5 liters of ringer lactate plus 1 liter of Pemacil. In the less than 15%, either ringer's lactate or 1 liter of Pemacil. But over here in class 2, you might need blood also. In class 3 hemorrhage, they have loss of 30 to 40% of circulating blood, 2 liters. They have tachycardia and loss of systolic blood pressure and decreased mental status. The patients are given 2 liters of saline over 20 minutes. Blood pressure should be maintained with crystalloid until the blood is ready. Recurrent hypotension, give 2 liters of crystalloid plus type-specific or non-cross-matched universal donor group O negative blood is given. So you have to keep an idea. What about class 4 hemorrhage? They have loss of more than 40% of the blood volume. They have marked tachycardia. They have significantly decreased systolic blood pressure, cold and pale skin. They have severely decreased mental status. They are confused and they have a negligible urine output. You should consider 2 to 3 units of fresh frozen plasma and 6 packs of platelets for every 5 liters of volume replacement. So you can imagine, you have to learn how to classify hemorrhage into 4 parts. You have to estimate whether the patient is a class 3, 4, 2, or 1, and then judge how you need to treat them. Disability or neurological evaluation. 50% of trauma deaths are due to head injuries, and you should be able to describe that. This is why we put the AVPU, FPU. A means alert. V responds to vocal stimuli. P responds to only painful stimuli. And U is not does not respond to any stimuli. We usually follow the Glasgow Coma Score, and these are the gradient should be 15, and if the patient has less than 10, then he is at risk for high mortality. And these are given numbers for each, and you add, مثلا, if the patient has spontaneous eye opening, we give him a score of 4. If he has a verbal response and oriented, we give them a score of 5. And motor response, whether he obeys command, we give him a score of 6. These amount to 15, and this indicates a good prognosis. Now, if he gets a score of 2, 3, and 1, and if he's below 10, then the mortality rate is high. Beware of the fact that cerebral autoregulation goes off following head injury. Beware of extensive sympathetic block due to regional anesthesia may hamper cerebral blood flow. Severe head injury, you have to use only life-saving procedures. If they have a subdural hematoma, this should be evacuated quickly, or any hematoma should be evacuated. This is a patient who has a subdural or an intracerebral hemorrhage, and you can imagine how sensitive, how risky it is. Now, in adjunct to primary survey and resuscitation, You have to follow the patient by electrocardiographic monitoring. Urinary catheter or Riles tube should be inserted, but be aware. Be aware of blood on the meatus. Be aware of a pelvic injury. Be aware of a sympathetic pubis injury, syndesmosis injury. All these cause ruptures of the urethra through the membranous portion. You can have occasionally ruptures in the bulbous portion. Now, a question I'm asked, how can you really tell whether there's a rupture? Of course, from blood in the meatus, and if you put your finger in the anus and palpate the prostate. If you see it's high up, this indicates there is a rupture. You have to take x-rays, cervical spine, as I repeatedly said, chest x-ray, pelvic film. Essential x-rays should not be avoided in pregnant women. Oh, RBG patient, she's pregnant, should I take? Well, she's going to die. You have to investigate. You have to forget somewhat about the child. So you have to follow these patients up. Let me see, it's covered up here. So I have to get this down. Okay, now we're coming to the secondary survey. Patients shows normal vital signs after primary survey, then you're justified to do the secondary survey. You should follow the patient from head to toe, evaluation, reassessment of all vital signs. A complete neurological examination is performed, including a Glasgow Coma scale. Management of life-threatening orthopedic injuries. All polytrauma patients with injuries of other organs like the spleen, liver, and kidney, major blood vessel tears, depressed skull fractures, and pelvic fractures. I'm going to go very rapid. This we have gone through. This is how they transport. They are log rolled. In all patients with spinal injury, maintain spinal precautions until thorough clinical and radiographic evaluation is completed. The spine is no more called as no man's area. Stabilization of the spine is mandatory. Prevent bed sores and try and mobilize your patients early. Now, what are the injuries of the spine? This patient is a baseball player, and while trying to catch the ball, fell and sustained a twisting injury of the neck and ended up quadriplegic. So you have to look at the cervical spine and you have to look at the anterior margin of the vertebral bodies. They should be in line. The posterior vertebral body margin should be in line. The spinal laminar line should be in line, and the spinous process line should be in line. Also, you should know that the amount of soft tissue in front of each vertebra is important. Yeah. At C2, the thickness of the soft tissue is 7 millimeters. At C3-4, it's 5 millimeters. At C6, it's 22 millimeters. This is common sense when you're looking at the cervical spine. Many times in the board exam, we put the cervical spine injury and we put it up and we ask, what you see abnormal? You have to know these measurements. And you say, sir, at the level of C7, there's more than 45 millimeters of swelling in front of the vertebral body. It's normally 22. Then we say that you know what you're talking about. These are the measurements I spoke about. This is more detailed. When you get the child in the injury, you have to recess the skull because the occiput is larger at this age and protruded posteriorly. So you have to put the child on a board in this fashion. Otherwise, you should have boards with holes in it and let the occiput subside within the hole. In adults, we put them in the photograph above. Looking at an open mouth view, many divers get fractures of the arches of the atlas. And we kind of wonder, by a simple X-ray, how can we tell whether there is a fracture? How can we tell whether the transverse ligament is torn? You look at this open mouth view. If you see that there's an overlap in the facet on both sides, then, my friend, you should think of a serious and an arch fracture, which is unstable. Many times you get the hangman's fracture. Hangman's fracture is a fracture of the pars interarticularis, and you get a displacement of the vertebra anterior on the one below. And if you look over here, you see, oh Lord, you see that the facet is intact. So this is a hangman's type 1, or this is a 2A or 2B. And then a 3 is where you get the facet completely displaced. So you know how to deal with these patients. You should know how you should reduce them. You should know when you should operate. This patient needs an operation, because if you apply traction from now to tomorrow, this portion won't reduce. So you have to keep this in mind. What about the abdomen and pelvis examination? You see, when you get a patient and you suspect a pelvic fracture and even had an AP X-ray of the pelvis, which tells you so, and the patient is hypovolemic, is hypotensive, he has tachycardia, you should put this clamp. This is devised, I think, by AO. It's a clamp that fits very easily. It can be applied in a very quick manner to compress the iliac bones together. This way, it would immobilize the pelvis somewhat and create a tamponade on the hematomas area and on the bleeding site, and it would decrease bleeding somewhat better than without. Or else you can apply an external fixator, and how to put the pins you should know. But the problem with this external fixator is that it's in the way of the hands of the surgeon. Okay, now I have to come out. You should inspect the abdomen for distension or other evidence suggesting gross intra-abdominal bleeding or injury in patients with penetrating trauma. Locally explore low velocity wounds to determine if the muscular fascia is penetrated. If it's not, then it's not serious. You put your, of course, in a gloved hand in the site of a clean wound and see if it has penetrated the fascia. If it has not, it means that the chances of it injuring the deeper organs is nil. So this, otherwise, if it has penetrated, then you have to do an open surgery to evaluate the injury. Now, you should palpate the iliac crest once for instability to detect significant pelvic fractures. Use a portable anterior-posterior radiograph to aid in detecting these fractures. If a fracture is diagnosed, avoid additional manipulation, because, fellows, if you're asked where is the most bleeding coming from in fractures of the pelvis, you should know that it's from the bone, from the periphery at the fracture site. It's not from vessels. In 15%, it's usually from a vessel which is ruptured. You have to keep this in mind. Okay, so please keep this in mind. Don't encourage any movement of the fracture fragments of a pelvis. Why? Because it would promote increased bleeding. Okay, am I clear about this? This is in anterior posterior pelvis. Radiograph quickly helps identify major pelvic fractures and joint disruptions. You can see, look at the symphysis pubis, which is open more than 2.5 centimeters. Look at the sacroiliac joint. Look at the displacement. When you get such a fracture and you see blood in the meatus, you should think of a rupture of the urethra. You have to keep this in mind. Inspect for evidence of bleeding, ecchymosis on the perineum. Why? If you have an ischial fracture, this will penetrate the perineum and you can bleed. Inspect for emphasis if you have a pubic ramus fracture. You should inspect the vagina. So the ischium, the perianal area from behind, inspect. Okay? In patients with a suspected spinal cord injury, record the anal sphincter motor tone. Yani, you should do a bulbocavernous reflex. You should see if there's any perianal sensation. Okay, be careful about this. You have to evaluate these points. Look at this patient. Look at the scrotum. Don't you think this patient has a symphysis pubis that is widened? And look at where the laceration is. So you have to think of something going very serious around the pelvis, and this patient is losing blood. So a pelvic binder was applied. This is the X-ray of this patient. Pelvic injury is one of the major causes for death. Pelvic injuries are assessed during secondary survey. Pelvis X-ray is mandatory in polytrauma patients. It can lead to life-threatening hemorrhage. 50% mortality. Think of it, 50% mortality if they have a serious pelvic fracture. Urethral injury, transurethral or suprapubic catheter can be used. This is the urethra. Over here is the area of the tear through the membranous portion. This is the bulbous portion. If this is torn, the bulbous prostate will go up. So don't forget this. Do a rectal. See if the prostate is way up. This would tell you whether urethra is torn. Or you have to do a, please, do a retrograde urethrogram on these patients. This is a retrograde urethrogram. You can identify the site of the tear if it's torn. Okay, am I clear? Now, during the resuscitation phase, insert a urinary catheter to facilitate measuring the response to fluid resuscitation. But placement of the Foley catheter is contraindicated if urethral injury is evident. The signs of urethral injury include blood at the meatus, ecchymosis in the scrotum, as I showed you, or the labium majora, a high riding prostate, as I've repeatedly spoken that it's stuck in your head to remember, and any of these findings, you should mandate a retrograde urethrogram to exclude urethral injury prior to bladder catheterization. Immediate management of severe pelvic bleeding. You should use pelvic binders, a military anti-shock garment. This was used in the past. Nowadays, due to necrosis from the skin, and due to compartment syndrome, we are not using it. External fixators, as I showed you at the beginning, if they don't stop the bleeding, you have to go in and you have to do pelvic packing. And in the final stage, you might have to do even angiographic embolization. So, pelvic binders reduce the pelvic volume. It allows clot formation. It allows for autotransfusion. But the disadvantage, as I repeatedly say, and I'm repeatedly saying it so that you'll never forget it, if we ask you in an exam, you'll immediately say that it causes compartment syndrome and skin necrosis. This is the position we put pins when we're applying an external fixator, as I showed you at the beginning, either putting this clamp or using an external fixator. I prefer to put my pins in B. Why? Because it is away from the surgical field if the surgeons want to explore that abdomen and repair certain structures. This is the external fixator being applied, but it's hectic to operate under anesthesia. And it gives us excellent anterior fixation, but not good posterior fixation. This is showing you on a patient of how it's applied. And one should do a laparotomy if he cannot control the bleeding, and he should do packing. This is showing you of how we do the packing. Angiographic embolization, the success rate is reported for experienced radiologists or intervention radiologists to be 95%. Most arterial injuries. مين عم يحكي؟ خالد في شيء؟
دكتور جون لا دكتور عبد السلام يمكن الصوت من عنده. دكتور عبد السلام كيف حالك؟ الحمد لله على السلامة. الدكتور جون بيسمعك.
عم بيسمعني عبد السلام؟
ايوه عبد السلام عم يسمع.
انا بسلم عليك يا عبد.
الله يسلمك دكتور جون استاذنا. يلا continue sorry.
Okay. Most arterial injuries involve the internal iliac artery. I want you to remember this. Which major artery is involved when you have an arterial injury? Remember that the internal iliac artery is the most common. You can have multiple bleeding sites in 40% of patients. Most common branches include the superior gluteal, the sacral, the internal pudendal, the inferior gluteal, and the obturator. But if you don't have an experienced radiologist, doing an embolization is risky because there have been complications, liver necrosis, skin necrosis, nerve damage, febrile head necrosis, bladder necrosis, and sexual dysfunction. Ya Jama'ah, you have to have experienced people doing these techniques. Otherwise, you can have complications. You have to have proper training. You have to have proper practice in the hospital of how to do them, when to do them, and what would the results be if not well done. What about damage control orthopedics? Damage control surgery, rapid emergency surgery to save a life or limb, not involving complex reconstructive surgery. يعني إذا عندنا واحد عنده كسر comminuted نحط له external fixator، ما ضروري ما نحط له plate, don't try and do the major surgery. Later on you can do it. Do the essential to stop the bleeding, to control the bleeding. If a patient has a depressed fracture of the cranium, remove the compression. If you have a pericardium which is teared and is bleeding, do a pericardiocentesis. If you have blood in the thorax, remove the blood. Abdomen and liver and limbs. Decontaminate wounds and ruptured viscera. Splint fractures, cast, traction, pelvic binders. These are all in the damage control. And damage control surgery is defined as rapid termination of an operation. We like to do an operation, but very quickly after control of life-threatening bleeding and contamination, followed by correction of physiologic abnormalities and definitive management. Patients for damage control surgery. You're doing stable patients, borderline, unstable, and extremely nearly dead patients. Now, let us speak about this. I have to remove the black to see if there's something I'm missing. Okay. Now, you have to, for stable patients, there's no life-threatening injuries, and these are hemodynamically stable. You can do it in early total care and start treating the patient. But if you have a borderline patient, these initially respond to resuscitation, but anytime can deteriorate. You should wait for improvement. In unstable patients, these remain hemodynamically unstable despite initial resuscitation. And you have to do damage control surgery. You have to do anything to try and stop the bleeding. And extreme is close to death, uncontrollable blood loss, and you have to do damage control surgery or ITU. Now, let me mention to you, there have been reported cases where patients have bled a lot from the pelvis and they were unsalvageable, and they went and did a hemipelvectomy and they saved the life of the patient. But the patient has to choose between one limb or death. Serum lactate levels. This is very important. If the serum lactate determination is less than 2.5 milligrams per deciliter, the chance of mortality is 5.4%. If it is 2.5 to 4.0 per deciliter, 6.4% mortality. And if it equals 4 or more, then it's 18.8% mortality. So the serum lactate levels help you in deciding what the future is going to be, death, high risk, or not. So don't forget, serum lactate. If you want to do an analysis, if you're in an examination and somebody asks you, how can you tell what are the risks on the patient? Tell them, sir, we will do a serum lactate level, and according to the level, we can estimate what are the risks on the patient. Don't forget this. Now, often it is high in the first few hours, but will drop if resuscitation is adequate. So 2.5, as I mentioned, is the magic number. If it's less, there is a less risk of mortality. If it's more than 4, high risk of mortality. Okay, don't forget this. Don't forget this. Early total care. Definitive fracture treatment within 24 hours. هيدي عم نحكي إنه if the condition of the patient is stable and good. Only in stable patients with lactates less than 2.5. So you can use the lactate to indicate whether you can do damage control very early in these cases. Avoid in thoracic injuries. Avoid in hemorrhagic shock and head injury. The advantage when you do this damage control and you do temporary fixation, you get pain relief. And we've noticed that there is less infection and early mobilization, and the incidence of thromboembolism drops. The priorities in surgical management of musculoskeletal injury is, don't forget, save life at the start. Second, save limb. Third, save joints. And last, restore function. This I tell to my orthopedic colleagues. Remember these 4 points, and you will be an angel. Save life, save limb, save joints, and restore function. What are the priorities in fracture care? The pelvis takes the first priority. The spine comes next. The femur comes third, tibia fourth, and then you look at the upper extremities. Don't forget this. Control all sources of contamination. You should remove all dead tissue. You should aim at preventing ischemia. You should allow pain relief, and you should put your patient in the intensive care and follow up in the intensive care. Now coming to fat embolism in polytrauma. Fat embolism, the incidence in polytrauma is 30 to 90%. If surgery, Ya Allah,
فينا حاجة ناكلها
our baby is attending the lecture.
شيء عشان ناكلها هذا.
Okay, if surgery is performed following polytrauma,
مش في البيت.
this can predispose the patient to fat embolism. In addition, if you're reducing a fracture and you're reaming the medullary canal, don't forget you are increasing pressure in the area, causing the pressure to go up to 400 millimeters. And this can promote fat embolism. Avoid increasing the intramedullary pressure. You should make sure, because fat can pass through the medullary channel, and this can predispose to fat embolism. We prefer to use a non-cemented prosthesis because we believe that fat embolism is less. Now we come to another condition which is very serious. It's acute respiratory distress syndrome. The pathophysiology, I'll tell you it in brief. It is destruction of the lung. Destruction and promotion of a surfactant lying between the alveoli and the capillaries. There's no longer any interchange, and there's shunting of air from one area to other. So the area of air exchange is much less, and this occurs secondary to any trauma. And as a result, they will have a decreased surfactant with atelectasis. They have highly membrane formation and fibrosis. This is a serious condition that occurs with trauma, multi-trauma. The diagnosis, you have to look into the medical history, do a proper physical exam and medical tests. They will have abnormal breathing or heart sounds. They have edema, means the heart or kidneys are dysfunction. You have to do an arterial blood gas test, chest X-ray, chest CT scan, blood tests for infection, heart tests, look for heart failure, acute respiratory distress syndrome, usually diagnosed in a hospitalized patient with critical illness such as shock, sepsis, or trauma. Don't forget this. And this is how the lungs will appear. And you see that the tissue is completely like a block, full of fibrosis. This is a very serious condition. The outcome, they have good function in many. You have to put them on respirators. You have diffuse pulmonary fibrosis and pulmonary hypertension in severe cases. The prognosis are extreme PO2 decrease and fibrosis. So don't think of it. Don't forget this. Look at the lung below. It's one block. It's solid. It's not full of gas. Facilities necessary during these procedures. You have to have a full range of implants and instruments must be available. It is the responsibility of the surgeon to ensure that her team knows what is going to happen. All those involved in the provision of surgical care for trauma patients must have regular training. Care of the patient does not stop once the surgery is completed. Normal intramedullary pressure is 30 to 50 millimeters of mercury. I'm stressing this. Violent force in the bone, intramedullary pressure increases it many-fold, and as I said, the pressure will go up to 400 to 600 millimeters of mercury. What are the negative effects of delayed fixation? Prolonged immobilization, pneumonia, bed sore, renal failure, inadequate nutrition, vascular abnormalities, and poor results. The timing of surgery. Day one, early total care, stable patients. Pay attention, don't forget this. Day one, early total care of stable patients. Day 2 to 5, avoid surgery. Day 5 to 10 is the window of opportunity. It's the chance where you can do surgery. After day 10, you have a high infection rate. I want you to look at the slide and remember it. That will tell you when you could do surgery on these patients. Now I'm going to take a break of 5 minutes, and we're going into a second session of the lecture. Khalid, is it good, clear so far?
Sir, okay, everything is clear, and it is a very informative lecture because it's basic, and we are interesting, me and all the colleagues.
ليك يا خالد يا ريت اجى حدا من المستشفيات لازم يعرفوا how they should prepare a trauma team. They should teach the EMT how to do a proper triage, meaning who should be sent to the trauma center, who should be sent to any other trauma hospital. Okay.
Okay, actually, yeah.
غلط انه يبعتوا مريض لمستشفى ويعرفوا انه ما قادرين يعالجوه لا يبعتوه لمستشفى تاني. This is wasting time on account of the life of the patient. You have to pay attention to this. This is very important. Okay.
Yeah, they are listening you, all the colleagues. Yeah, with you.
Yeah, I had so many phone calls. So many phone calls.
Yeah.
I will answer them later on. Type. I'm going to take 1 minute and then I'll come back.
Okay, you can take rest about, as you told, 5 minutes.
Okay, take 5 minutes.
Rest 5 minutes. Any question from the colleagues, they can ask you. Or
Okay,
any,
1 minute. Just 1 minute.
يا صلاح. دكتور عبد السلام. يا دكتور صلاح. دكتور صلاح. دكتور صلاح. شباب، أي واحد من اللي بيسمعوا أي استفسار، وهذه محاضرة رائعة جدا كلها بيسك يعني، واللي ما يعرف يعني الحرف فيها يعني بيكون منقص شيء يعني. بيسمعونا الشباب يا صلاح. الدكتور عبد السلام أنا أيضا رسلت لمصطفى وأكرم على أساس أي حد من عندكم يعني حاب يدخل وممكن يدخل في المحاضرة على طول.
دخلهم هلا إذا بدهم يدخلوا.
أي ما إحنا معطيهم لصنعاء موجودين نسبة وعدن، وفي بعض من الدول العربية الشقيقة، من ليبيا، من مصر، عراق، دكتور كرار وكثير.
لك عم بعطيهم the basics خالد، عم بعطيهم the basics what they should know.
Yeah, sure. And this يعني الكتشر هذه مهمة جدا في حياتهم العملية. وبصراحة دكتور احنا يعني بالنسبة لتوزيع البورد سنة ثانية بيكونوا أكثر ارتباط بالتيم هذا، يعني في الإمرجنسي عادة بيكونوا وبيشوفوا حالات كثيرة يعني، وعندنا عارفة حالات الحوادث الكار اكسيدنتس والبن شوتس كثير، ويعني مليان بالهبل عندنا. فهم بيطلعوا على، والمفروض يعني بيسوي المحاضرة بتاعتك بتسوي لهم اورجنايزيشن لمعلوماتهم.
مظبوط.
أي سؤال من أي مكان شباب ممكن تحضروا أو تستفسروا.
هيئتهم فهموا كل شيء.
باين خلاص، بعد أنت تسألهم ولا نسألهم ما يقولوا ما حد هذا فاهم كل شيء. دكتور عمار وهبان، أنت عاوز تسأل ولا شيء ممكن يعني تسأل. ما أدري من مسوي شاتنج هنا.
السلام عليكم دكتور خالد.
مرحبا وعليكم السلام.
سؤالي يا بروف عن التايم اوف external fixation في الدمج كنترول سيرجري عند بلفك. نحن بنحطه قبل الباكينج او بعد الباكينج البلفك.
ايوه دكتور جون، الدكتور عبد الكريم بيسأل. يا عبد الكريم علي صوتك ويعني وضح سؤالك للدكتور جون.
او انت اللي لا انا عم بسمع صوتك كثير منيح، هو انجأ سامعه.
عبد الكريم ممكن تعيد سؤالك على الدامج كنترول بالبلفيك سيرجري صح او بالبلفيك تروما؟
ايوه تماما. الباكينج في البلفيك سيرجري نحط الباكينج قبل الاكسترنال فيكسيتور او بعد الاكسترنال فيكسيتور؟
وات خالد شو عم بيقول؟
دكتور جون، عبد الكريم بيسأل يعني في حالة البلفيك تروما يحط الباكينج قبل ما يسوي الفيكسيشن عادة. اعتقد قصدك اكس فيكس صح يا عبد الكريم؟
تماما.
يلي انا عم بقوله انه if you have a patient who has a significant fracture of the pelvis, mind you, you can have a combined open book and a hemidislocation of the pelvis. These are very unstable. وهول إذا بقيوا يتحركوا بيضلوا يعملوا cause للبليدنج. من هيك اللي you have to put either a binder, which is not very efficient, or a clamp, an external fixation clamp or fixator. But you have to put it in such a way that it will be out of the way of the surgeon. لحتى إذا عنده شيء organ injury يقدر يعمل له repair.
Yeah. Either also the type of bleeding, either it's bony bleeding or يعني venous or arterial. It is different أيضا عبد الكريم. أنت بتسوي assessment.
هيدي طبعا. بالarterial you have to do something, you have to operate, you have to go in or repair the vessel, or you have to do embolization. But if you have bony bleeding, which is in 85% of the cases, you cannot take care. Okay? رح بلش لأن
Okay.
I have a long section. Okay,
you can start.
This section consists of some repetitions and more detailed discussions. The reason why I put it in such a way, then I want you to retain the knowledge I'm trying to give you. Because this is the way we should give in digital teaching. What we're doing is we're giving you a lecture and we're depending on you on how much you will benefit or you want to benefit from this lecture. We're trying to force it upon you to learn. I'm sorry I'm telling you this. This is the basis of digital teaching. Okay? Now, you have to think that you can have an injury to multiple organ systems. You have to think that this could lead to metabolic diseases or metabolic problems, metabolic processes which are disturbed. It interrupts even endocrine function. It creates a hemodynamic and physiologic instability and leads to highly lethal systemic diseases and multiple organ failure. Injury to multiple organ systems. It requires a team approach, which I have spoken about. You have to, don't forget, it should be orderly. The emergency medical technician should work together with the team. He should phone and say, on the way coming, we're getting this patient. He has such and such, so that in the trauma center, that they should have everything ready so as to process the patient and evaluate him properly. Now let's come to several conditions. The polytrauma patient, the patient's condition at first contact. You should look and rule out neurologic problems. This is the emergency medical technician. He should know whether the patient is able to breathe or not. He should look at the respiratory status, and he should look at the APVU, meaning the responsiveness to talking, the responsiveness to external stimuli. So this is the team waiting. This is how they're organized. So don't forget that we don't like tunnel vision. We like multidisciplinary approach. Don't forget that while they're working on the patient, the nurse and the resident should create a flow sheet, record everything down, everything. Then you have to think of nutrition, infection control, pulmonary function, skin care, rehabilitation, psychological support, occupational programs, and physical therapy. You have to organize the system in your mind on how you're going to manage your patient later on. The incidence of missed injuries approaches 10%. And this is a question we always like to ask. Missed injuries. What is the incidence that we miss? And that we spoke about this at the beginning in patients who have head injuries, alcohol intoxication, intubation. These are all causes for us to have missed injuries. Okay? Now, we spoke about this. We spoke about, if you have a patient diving and he sustains a fracture of the cervical spine, you should apply the board when the patient is in the water. Don't remove the patient and apply the board while the patient is on the floor or getting him out. If they're on a football team and they're playing this crazy football, American football, and they get an injury and they paralyze, remove the mask, don't remove the helmet. This or هيك. Can you tell me what has happened? Okay, we spoke about these. We spoke about this. The best place of position is to put the patient on the back, intubate him. This is showing you the emergency medical personnel all working together, each one doing his job. They have to be organized, low voice, listen to the captain, always undress the wounds, pay attention to breathing, circulation, and the neurologic status. Okay, always ask for these. Let me see, I'm trying to see if there's anything I would like to mention. Now, what you receive in the emergency room, وهيدي اللي بقول لهم اياها للريزدنت. I'll tell you, when I was a second-year resident, I was in Canada. I was in the emergency room, and I received a patient where a truck hit the bull, and the bull landed on the patient. And the patient was brought with a very narrow pulse pressure and was not able to breathe. We intubated the patient. We could not get him to breathe on his own, and we could not build him up. So what did I do as a second-year resident? You know, I was a bit crazy. I asked for the scalpel, and I made an incision through the intercostal space between 4 and 5 on the left side, and went down to the heart, and I found that there was a huge amount of blood in the pericardial sac. I incised it, evacuated the blood, and closed it, and believe it or not, the patient survived. Mind you, I'm not telling you to do this. I think this was a crazy act from a second-year resident who was trying to show off and nothing else. So we have to think of tension pneumothorax, open pneumothorax. You have to think of a flared chest, massive hemothorax, and cardiac tamponade. With a tension pneumothorax, لما بيكون عندك جرح بالchest ومفتوحة connecting with the pleural cavity. إذا الواحد بده يتنفس الهواء بيفوت لجوا، ما بيفوت من تمك، بيفوت لجوا. شو بدك تعمل؟ you have to pack it, compress it, and pass a tube through another region so as to deflate the area from gas coming in or air going in, and then repair the wound. So this is one technique you should do. Tension pneumothorax. These patients have absent breath sounds, is abdominal percussion. You find that it's hyperresonant. And what happens? When air goes into the lung, around the lung collapses and presses on the opposite normal lung, and it tightens its gap, and it gives you this hyper resonant to percussion. And on the normal side, you see that the lung is compressed. What would you do with the tension pneumothorax? You go to the second intercostal space, you get a bore needle, you feel for the mid aspect of the clavicle, and you go in the intercostal space, you pass your bore needle, and then you remove all air from the lung in the case of a tension pneumothorax, and then you put your drain in, your tube in. Okay, and open pneumothorax, I spoke about. A flail chest. You have to pay attention. With a flail chest, you will have paradoxical chest wall motion. With inspiration and expiration, impairing ventilation. Pain results in restricted motion. Both lead to hypoxia, and you have to intubate in these cases. This is what I'm trying to show you. You can have also massive hemothorax, rapid accumulation of at least 1,500 cc's of whole blood in the chest, may be the result of blunt or penetrating trauma, hypoxia. Restore the blood volume, decompress with a chest tube in case of massive hemothorax. And this, if it does occur, and it's massive, you should do a thoracotomy and repair the source of the bleeding. This shows you a massive hemothorax that required the tube and drainage. Don't forget the proper physical examination. Also, you should do an estimation of the urine output. And the normal is 0.5 millimeters per kilogram per hour in adults, and 1 millimeter per kilogram per hour in children. Oxygen saturation by pulse oximetry reflects well the patient's airway. You should do a central venous pressure. This provides information regarding atrial filling pressures. Elderly, you need to do with severe thoracic trauma, you need to put a pulmonary artery catheter. Okay, so these are points you have to stick to. Now, hypotension in multiply injured patients may be due to diverse causes, as I have repeatedly mentioned in this lecture. But don't forget that sternal injuries, secondary to steering wheel injuries, can cause major artery injuries, and you can have massive bleeding from a transected aorta, and this is really a death-killing injury. You have to do, and is still popular, peritoneal lavage. This I leave it to the surgeons, which will tell you whether there's any major bleeding in the abdomen. CT also helps. And in Europe, they do an ultrasound and they depend a lot on it. This is, let me see, what else do I have? Presenting with don't forget about thrombocytopenia that can occur from repeated blood being given. You have to give fresh frozen plasma, platelets. Don't forget about this. And if you cannot find the proper blood, you have to give Rh negative blood. Cardiac tamponade, I spoke to you about it. It results from penetrating injuries, and this can be confused with tension pneumothorax. Okay, this is a tamponade. Don't forget about Beck's triad. This is asked in examinations, which consists of venous pressure elevation, a decline in the arterial pressure, and muffled heart sounds. Don't forget about Cosmal sign. This is a rise in the venous pressure with spontaneous inspiration and may be present in cardiac tamponade. So, cardiac tamponade, you use an abdominal ultrasound, and focusing on the pericardial sac may be performed and diagnosed. You need a prompt evacuation of blood, and that's why I told you the technique of how to aspirate from a pericardial sac. Don't forget, at the xiphoid, you pass your needle 15 degrees and aim to the opposite shoulder, and you'd go into the apex of the lung, and then you can aspirate. Okay, so don't forget these points. Don't forget about the breathing. Don't forget about the Glasgow score. Please, these are points all important. I would like to mention the organ which is most commonly injured is the spleen, followed by the liver. Now, in the past, we used to do a splenectomy. Nowadays, we don't do a splenectomy because this interfered with the immunity of the patient. We repair the spleen. It can be quite difficult at times, but we repair it. The lung, the liver, you can repair it, but at times it can be extremely difficult. Don't forget about CT scans. Don't forget, CT scan will tell us about if you have rib fractures, they can penetrate the liver. So don't forget about this. I'm going very quickly. Don't forget about the proper neurologic exam of how to do a bulbocavernous reflex, do sensation around the perianal side, and see whether the patient has a complete or not, or whether it's a neuroshock or not. Now you have to distinguish between hypovolemic shock and neurogenic shock. In neurogenic shock, you have bradycardia plus hypotension. In hypovolemic shock, you have tachycardia plus hypotension. In the past, whenever we used to get the patient who had hypotension, we used to pour in blood. But what was the result? Many of these patients ended up with lung edema. So you have to pay attention to this. Don't forget about these x-rays. Don't forget that you should do a rectal exam to see whether the prostate is elevated. You have to do a retrograde urethrogram. Many times you have to insert the avoiding cystogram and put a suprapubic catheter because you have a ruptured urethra. Okay, so this is it. Now, there is a sign that we have on the skin of patients who have pelvic fractures, and this is called the Morel-Lavallée lesion. And over here, if you're operating, you should not go through this area because you will get necrosis of the skin. Okay, so please pay attention. Now, in the fractures of the pelvis, I thought of giving you briefly about it. In the fractures of the pelvis, you have lateral compression, you have an anterior posterior compression where the sacrospinous ligament is torn and it gives you an open book injury. You have a vertical shear fracture where the sacrotuberous ligament is also torn and it would give you a vertical displacement and combined mechanism. So you have to ask for all the x-rays of the pelvis in addition to pelvic inlet and outlet views. So don't forget this, okay? Another important point, in closed book fractures, these patients lose much less blood than patients with an anterior posterior open book fracture. Don't forget this, when you have a closed book, it compresses the hematoma. When you have an open book, it decompresses. So you'll have much more bleeding, okay? Be very careful about this. Open pelvic fractures are high energy injuries and carry a mortality rate of 50%. And they have significant displacement and a high risk of deep infection. The ischial rami produce the open wounds in the perineum. Sigmoidoscopy in female, the pubic rami can produce an open wound in the vagina. I mentioned this. So you have to pay attention to this. You have to look into the vagina, you have to look into the perineum, look into the area, because many times you would have to do a colostomy for the general surgeon. This is a female who had a fracture, but she had blood in the vagina. So you have to pay attention to this. Due to pubic rami fractures, this is a male who had a fracture, and you have to look into the rectum, because at times you can have ruptures of the rectum from the fracture. And this is the pelvic emergency pelvic binder. And these are views of how to do. These are the same things. I'm just telling you this because in these fractures, you might end up with a colostomy. You need, especially in open fractures, the risk of infection is high, and you have to apply all the means to try and compress the fracture and immobilize to create stability to prevent further bleeding. I'm going these very carefully because I want you to realize it. I'm showing you these cases. Some of the cases are my cases, some of the cases are borrowed cases from the literature. So you have to pay attention to this. You can have hemifractures. You have to think of acute respiratory distress syndrome throughout. You have to think of always instability of the pelvis. Over here is where I'm mentioning that lateral compression fractures or closed book fractures, you bleed 3.6 units of blood. In AP compression, anterior posterior compression injuries are 14.8 units. So you have a higher incidence. But in lateral compression fractures, you have more head injuries. So pay attention to this. Open reduction is done as a delayed operative procedure when progressive hemorrhage is not apparent, because they often will decompress tamponated bleeding surfaces and promote further bleeding. And I like to operate the pelvic fracture. If bleeding has stopped, I like to operate them on the 5th day. Okay, and if you have an open book fracture, and if the symphysis pubis is open more than 2.5 centimeters, then you have to put the plate. But don't forget, this is not sufficient. You have to make sure that the sacroiliac joints are stable and not injured. You know, being that the sacrospinous ligament is still intact, and it's only through the anterior sacroiliac ligaments and the sacrospinous ligament that has been torn. Okay, this you have to pay attention. We spoke about all these intensive care units. We spoke about them. For embolization, we can insert gel foam or coils. And as I told you, you need an experienced radiologist, intervention radiologist. Okay, lower extremity injuries, fractures result from high energy. If unsplinted, they may lose up to 4 units of blood. And this is associated with acute respiratory distress syndrome. And tibial fractures, you have high incidence of trauma. These we will be discussing in the future. And you have to pay attention to them. Let me see. These are what I've told you about fat embolism and acute respiratory distress syndrome. I just would like to add that at the site between the alveoli and capillaries, you have a release of interleukin-6, interleukin-1, tumor necrosis factor. All these produce edema, and they prevent exchange of gases. Fat embolism, we spoke about this. Each one of you should go through it, but there will be separate topics in the review course on it. Be careful from thromboembolism. Put your patients on low molecular weight heparin. If you're afraid from bleeding, in the meantime, just put them on special compression devices. And if necessary, you can use a vena cava filter. So be very careful from this. Respect the soft tissue. Don't forget about compartment syndrome. It does occur in open fractures. Don't forget about the tissue pressure. This is a striker slit catheter technique that you put your pin, it's a special pin, you record the blood pressure around 5 centimeters from the fracture site. It records the pressure. It should be less than 30 millimeters of mercury, and the diastolic should be less than 20 millimeters, different than the normal. And this is when you judge whether you need to do decompression, a compartment release of either 4 or 1 or 2 or 3. Okay, so don't forget, and this I tell you, thank you, thank you, thank you. Any questions?
Thank you, Prof, for your very nice presentation. And let me
How do you like the final slide?
The file. Very nice.
I think we need this in all our areas.
Yeah. Here, one shot and the child up, huh? اوكي صلاح دكتور عبد السلام اي سؤال اي شيء؟
شو يا عبد؟
شكرا كل شيء obvious, everything is obvious. Thank you.
Was I clear?
It is clear for us.
Dr. Abdelsalam is my companion in the examination board.
Thank you, Prof.
And
Thank you,
believe
thank you.
me, he
Everything is
knows a
okay.
lot. He knows a lot. And I
Thank you, thank you.
congratulate Dr. Khalid and Abdulsalam for their eagerness and will to
Thank you,
educate
sir.
the resident body. Yalla.
Thank you, sir. And we hope the colleagues get benefits, the most benefit from you. Thank you very much.
Thank you. Yalla, bye-bye.
Bye-bye.
Next Friday, huh?
شكرا شكرا.
Yeah.
Bye.